morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honored guest from Switzerland, Professor Oliver Bozinov. Professor Bozinov is the professor and chairman of the Department of Neurosurgery at the St. Gallen University School of Medicine, Switzerland. His clinical interests are focused upon intraoperative imaging, tumor and skull-based surgery, vascular surgery, and childhood brain tumor. He's also the president-elect of the Society of Swiss Neurosurgeons. He's a noted author with several publications in various peer-reviewed journals, as well as an invited speaker at several conferences worldwide. We are extremely honored to have him today at our webinar, and today he'll be talking about laser interstitial thermal therapy for brain tumor. The speaker for the second session today is our honored guest from China, Professor He Chuan. Professor He Chuan is a chief physician and deputy chief physician of the neurosurgical department of Zhuangwu Hospital of Capital Medical University. He's the first standing member of the neurointervention professional community of the Chinese Medical Association, the first vice chairman of the youth committee of neurointervention of the Chinese Medical Association, the member of the youth committee of severe cerebral vascular diseases of the Chinese Stroke Society, and the member of the intravascular therapy group of the neurosurgical branch of the Beijing Medical Association. He was trained under giant of neurosurgery like Professor Wu Junjia, Professor Ling Feng, and also Professor Takashi in Japan. His clinical interests are focused in the management of treatment for the cerebral aneurysm, cerebral arteriovenous malformation, and spinal vascular malformation. We are extremely honored to have him today at our webinar, and he'll be talking about craniovertebral junction AV fistula. The chair for the first session today is our honored guest from United States of America, Professor Alireza Mansouri. Professor Mansouri is the associate professor in the Department of Neurosurgery at the Penn State Cancer Institute, Pennsylvania, United States of America. His clinical interests are focused upon brain cancer trials, surgery of brain tumors, and epilepsy surgery. His literary contributions sum up in score of international publication and book chapter. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for second session of today's webinar is our honorable guest from Canada, Professor Ashish Kumar. Professor Ashish Kumar is the assistant professor at the Department of Neurosurgery at the Sunnybrook Medical Center, Toronto. Professor Kumar field of expertise is in cerebral vascular and endovascular surgery. He joined the division of neurosurgery as the surgeon teacher at the Sunnybrook Health Sciences Center and developed a clinical practice center in open and endovascular care of patients with cerebral vascular diseases. His main interest is to increase exposure and foster the interest of neurosurgical residents to endovascular neurosurgery through the development of core curriculum in the specialty simulation and a protocol for dual training and optimal cerebrovascular exposure during neurosurgical residency. He's a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both speakers and chairs and the wonderful audiences to this online platform of ACNS webinar. A warm welcome to our colleague from China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on the WeChat channel. With that introduction, I would hand over this online podium to our first chair, Professor Alireza Mansouri. Professor, please.
Good morning, good afternoon, good evening. Thank you very much for the kind introduction, and nice to meet you, Professor Bozinov. Looking very much forward to your excellent talk. It's a very exciting and innovative topic, and looking forward to what you have to say. Thank you.
Oh, thank you very much for this introduction. All right. Well, thank you very much for the introduction. And I'm very happy and thankful, Raja Krishnan Kuti, who invited me to give this talk in your society. It's great. And he asked me, what shall I talk about? And I gave him three options, the usual ones that I love and that I like to lecture, of course. And laser therapy was one of them. And he said, wow, this is cool. We never had such a lecture, so we should take you. We should take this one. And interestingly, so for you guys, because this procedure or this technique is commercially not available in Asia yet, it will be really new. And I'm happy to tell you about it. But Dr. Mansouri comes from the US, and they have this procedure already for 13 years, and we have it for 3 years in Europe. So I am the junior for Dr. Mansouri, and the senior for you guys. So it's a funny situation. Anyway, I brought some slides. I will talk about how we do it. But before I start, I have to talk very slightly about me, which I usually don't like. But I think since I talk to Asian colleagues, it's fair to say where I'm coming from. I'm coming from the very small land of Switzerland. But as you know, it is famous for its mountains and also some other financial things. However, I'm coming from the east side, from St. Gallen, and we cover basically the complete east part of Switzerland. It's very hilly and very green in our city, and hopefully someday you can come and visit us and see the beautiful life we have here. Now, for the disclosure, I have to say that I'm frequently invited by Medtronic to give lectures or to provide information or be on a board. And but this lecture here was not invited by Medtronic. It's completely free, so I can disclose that. And some of my studies started at the University of Hospital of Zurich, which is in the middle of Switzerland. And now again, I'm in St. Gallen, so I continued my studies there and my patients there. So I don't want to go too deep into the theory of laser therapy, but because I didn't invent it, I have to admit, I'm using it and I like to use it, but it was not my invention. So I'm just showing you my clinical experience. However, laser started, maybe you've heard of YAG laser, which started in the 80s, 90s, that light and heat light was used in the brain in earlier days in Japan and in Germany, starting with some good publications, but somehow it stopped. The invention got lost basically, and some people continued, and eventually a company was built, Visualace, and this company was taken over by Medtronic, and Medtronic started to distribute it in the US about 13 years ago, or about, I don't know, maybe more, maybe less. But then again, the approval, the so-called FDA approval in America, but in Europe it's different. The approval for Europe came about 3 years ago, and we started immediately too. And the idea is that if you have tissue and you heat up tissue, for example, you heat it up by 43 degrees Celsius, this is a critical temperature for tissue, you will need hours until this tissue dies. If you have a temperature about 90 degrees, it takes like a second or two and the tissue is dead. So that's easy. However, what you want is basically a temperature, for example, between 50 and 60 Celsius. It takes a time-dependent, it's time-dependent to have denaturation of the tissue. And what you don't want in a head, because it's like a pot, you don't want vaporization. You don't want to heat things up over 90 degrees, so you have gas, and then you have brain pressure, etc. So you would like to stay in the middle of this here, and you would like the computer to know how long, what heat have you given to the tissue, to know that the tissue is dead, and of course that you don't do too much harm. So the company has this catheter with light, with laser light. This catheter is introduced into the head, stereotactically ideally, but you can do it navigation. Of course, then you have an arrow of what maybe 1, 2, 3, 4 millimeters, and depending what technique you use, but you have to implant this catheter. And then you go to the MRI, and that's also something I didn't know. An MRI can measure temperature or can measure the difference of temperature. So you basically put a reference somewhere in the brain and tell them that's 38 degrees. And then the MRI can measure around that area of interest what temperature is going on there by less than 1 millimeter distance pixel. So it can measure every 5 seconds the temperature change in that area. And this information goes to the computer. The computer can say, okay, this area had 60 degrees for 10 seconds, this tissue is dead. And then it makes, you can see on the right side, the heat map. So it's red means hot and blue means cold. And then on the left side of it, you see the yellow, which means this area, this tissue is already dead. You can burn it 2 times if you want, but it's already there. So this area is of course around the catheter. So that's the theory. So you have to put in some targets, how much temperature you want, how much temperature you must not want at one area because it's eloquent, for example. So all these things this computer can do, and it's then very easy. It's almost like radiosurgery for the surgeon to push the button and then eventually stop. So in a small cartoon, you see that. So the heat heats up and then the tissue dies, and then you can pull back, of course, the catheter. And this way, kind of like a sausage, you can denaturate tissue and you can kill tissue. The problem is the tissue can be not bigger than 2, maybe 2.5 centimeters. If you have bigger lesions, then you need more catheters, for example. And then you have to ask yourself, maybe an open surgery might be smarter. Now, next. So this is how we started. This was one of our first cases. So you bring the patient, I just so you for understanding, a video might help. So you bring the patient to the CT, you put in the ring, the stereotactic ring, you can see it here. You do a stereotactic CT. With this information, we usually go back to our lab. We plan the navigation. We use Medtronic or BrainLab or any other navigation system. And then you have the coordinates for the stereotactic puncture and insertion. You can see this is the biopsy puncture, but also for the insertion of the catheter. Now you see the only burr hole you do is 2.5 millimeters. So this is no injury to the patient. It's very nice. The patient is very awake after surgery. They have no complaints, basically. So that's the beauty of it, basically. The question is, why are you doing it? Next day, they can go home. So you insert the catheter for the laser. Then you transfer the patient to the MRI. We do it still sleeping. We don't do it awake. Some people do it, but we do it sleeping. And you can see now we warm up in the MRI. We warm up the tip of the catheter. And the MRI is measuring constantly the temperature and giving us feedback. And this way, we basically kill the lesion and denaturate it. But we don't take it out. We don't take out the cells. That's the difference. That's what you have to explain to the patients. The great thing, it's minimal invasive, 2 millimeter burr hole or 2.5, heat-induced tissue ablation, cytoreduction, very fast recovery, and pretty much high safety. We have to say that. So that was actually my first case. I will explain it later one more time. And we published our initial ideas and results together with Peter Nakagi from Phoenix in Cancer Letters. Now, this therapy, again, is known very well in the US for more than 10 years. And of course, our colleagues are ahead of us. So Dr. Mansouri, again, knows this technique much better than me, from his colleagues and himself, of course. And the breakthrough really, which laser had, is in epilepsy surgery. So all these colleagues you see on the left side, they did studies with laser therapy for epilepsy. And all these studies show that there's a clear benefit than not doing this procedure. So nowadays, if you have a child with amygdala hippocampus epilepsy, in the US, most centers really primarily do the laser ablation first and then the open hippocampectomy. So, Dr. Mansouri can comment on it, at least that's what they tell us, because here in Europe, we start to do that too. So we start to offer patients and parents of small patients to use first laser therapy instead of open surgery for the kids. So the evidence level is pretty good for epilepsy. So it's really, we have randomized trials. We have a good level B evidence, class 1. So for many of these lesions, laser therapy should be used. Now, another thing that's very interesting, radionecrosis. You know, if you do repeated radiosurgery, stereotactic radiosurgery, you have a risk of 50% that you get a radionecrosis. So these cases occur quite often because we use it more and more. So after the second radiosurgery, you see the numbers go up very quick. And those patients have radionecrosis, need cortisone or Avastin or something. And laser therapy plays actually a role here because it's a very nice randomized trial here from Dr. Chang and his group and a multi-center group. And you can see above here that if patients had maybe only a radionecrosis or a metastatic tumor, a metastasis, you can see that for many, many weeks, this lesion was stable. It was not recurrent or progression. So it was stable, and especially the radionecrosis, you can see the 100% line went a lot of weeks. So especially the radionecrosis patients profit a lot from laser therapy instead of taking a cortisone. I can show you a case of mine that I used, and it shows it very nicely. You see a patient with a lung disease, and she had a metastasis. She had radiosurgery on this one in 11/2018. Then this lesion was growing, and you can see also the edema around it growing just 2 months later. And another 2 months later, the lesion was growing further, and the edema was growing a lot, and she was taking cortisone now for 2 months already, and having of course, side effects. So in this case, we decided for laser therapy. We didn't know whether it's only radionecrosis or metastasis. So we actually decided to make a laser therapy even larger than this lesion because it's not eloquent. And so you will see the lesion that we do is bigger. That's intentional. And on the other hand, of course, you could have done an open surgery here, or you could have given cortisone for a long time, or Avastin. So here we decided for laser therapy. You see, just a month later, you see the lesion that we produced, but you can already see no edema. So within days, actually, this edema went away, and we could stop the cortisone. You can see here also a couple months later, also this lesion collapsed. There's almost nothing left of this lesion, and you can see comparing the FLAIR imaging, you see that the edema right before laser therapy was huge, and it was basically gone within a couple of days in this case. Sometimes edema can become higher. We still don't know what cases profit more or less. But again, radionecrosis, we know for sure, not for sure, but most of them really profit from laser therapy. And so the evidence is pretty good too for radionecrosis using laser therapy. Now, this was our first patient that we treated with laser therapy in Zurich. My first patient was very easy because this patient, you see, it's a deep lesion again. Open surgery means that you have to go through healthy tissue deep to get this lesion out, or just do biopsy, of course. We offered biopsy plus laser therapy. She immediately said, I want this. You know, she wanted to wait 1 more week to plan everything. So we did this. You can see the laser ablation in the lower images. So went with a catheter a little bit through the lesion, but we can always pull back. It's more difficult to pull more in. And then she had radiotherapy 2 months later, and she was treated, of course, with the standard SHUP regimen. But what came out was a glioblastoma in that lesion. And then in the tumor board, the neuro-oncologists were a little bit shocked because they said, okay, that's a nice therapy, but we cannot offer this patient a study now because all studies are either biopsy or resection, but no study includes laser therapy. So that was kind of funny because we had to think now, what shall we do with the patient? Give standard therapy or include her? We can't include her in a study. So we didn't know that before. So now we know. So the question, and for this talk, is, are gliomas at all good for laser therapy? Because their shape is irregular, it's an invasive character, we see only the contrast enhancement, but the lesions are bigger. So why even use it for that? That was a big question also in the US and for us Europeans. So we have to admit that the evidence for using laser therapy for glioma really is a class 3 level C. So for very limited and only on expert opinion by now. So we don't have good randomized controlled trials to prove this. So right now we use recurrences, or we use patients that are too sick, deep lesions, not all good for open surgery, and then we offer this. But we have to tell patients that it is not off-label, but it doesn't have this randomized controlled proof as others have. However, in some cases, laser therapy can have a very good impact, at least we think this. For example, this young boy, 17 years old, neurofibromatosis, has a lot of lesions in his brain. This one in the optic tract was getting larger and larger, and we said we want to do a biopsy, because if there is any target that we could give for this patient, because fibromatosis, radiosurgery is not ideal, or any kind of radiation is ideal for these kind of patients. So maybe there is some chemotherapy. And then the patient father also heard of laser, and we offered it, and we did this procedure. So we planned this patient. You can see the lesion with contrast enhancement, so most likely, and it was a pilocytic astrocytoma at the end. We went from behind with the catheter. We ablated this lesion. We left a little bit on the upper part because of the optic tract loop, because we didn't want to make any kind of partially hemianopsia on this patient. And you can see this lesion collapsed, and a little bit tiny residual was left on the top. Of course, he has neurofibromatosis, so you can't heal this patient anyway, but we wanted to stop this growing. And this worked fine, and until now, this lesion is stable and it was not growing anymore, and that didn't need further therapy. Now, another case that fits also, in my opinion, into this category, it's another child that we operated here. It was, you can see up here in 2020, it has this lesion, and this mother was very, very nervous about it. She read a lot about medulloblastoma, things like this, and gliomas, of course, and we were pretty sure this is just a pilocytic or something else, and we said we should wait. She had an offer to get operated outside somewhere, open surgery, which I really don't understand. I think your risk to missing this is much higher than finding it. However, she waited, and then this lesion got a little bit more contrast. She got more nervous. And so we said, okay, we can take care of it. We can biopsy it, and we can use laser. And so we avoid open surgery on this case, but we can still kill this lesion. And that's what we did. We did a stereotactic from the back. So the boy is kind of like a sitting position. You can see it here. We did a biopsy. We put in the catheter, the flexible coils in the MR. And again, on the right side, you can see the lesion, again, a little bit bigger than the contrast enhancement, because we were sure it was a benign lesion, and we really wanted to get every cell of it. So to be sure that this lesion basically is done. Kid has no neurofibromatosis, so we can actually heal this kid. So we did a little larger lesion in this case. But this goes very quick because it's a small lesion. It just takes less than a minute to heat this up. So you can see the heat temperatures here, 39.8 on the outside, 44 degrees in the center. We have, and then in two planes, you can see what your heating is doing. And on the right side, you will see how many dots are already yellow, and did you get the whole lesion, basically. And this is the boy a week later in the outpatient clinic. You can see the ataxia is not very much, so you can do the finger test, you can walk, and you can see actually on the back of his head, you can see the little crust. So that was a week after surgery, and it was doing perfectly fine. And even with open surgery, I know kids are quick, but anyway, nothing is quicker than laser therapy compared to open surgery. These patients are doing really very good. The only downside of it is that you have to get used to see some kind of contrast enhancement also many, many months after a lesion, after a laser procedure. So even a year afterwards, we see a dot in the middle of the lesion of contrast enhancement. It probably takes many years until this is gone, but there is no active tumor anymore. It's really a scar. But again, that's the downside of it. So you can't tell the mother, look, there is no contrast enhancement, so there is no tumor. As you are used from open surgery, you cannot do that anymore. Now, there are some publications about using glioma in these cases, and you can see that all of these different cases, metastatic, pilocytic astrocytomas, GBM, they all had an increased edema at day 1, and most of them, but not all, most of them, the edema went down quickly in the first month. So there is some issue with edema, yes, but it resolves very quick in most cases, and it really depends on the size of the lesion you're ablating. So if you're ablating a 3 × 4 centimeter lesion with 2 or 3 catheters, you will have a lot of edema. If you take care of a 5-6 millimeter lesion with just a tip, then don't worry about edema. So that's really the essence of it. So we actually avoided to do tumors with multiple catheters. So far, we have used only 1 catheter, and it's also a cost thing to consider. Now, this is a very, very important paper from Dr. Sharma, and he's very brave to bring this paper. And you have heard a lot of papers that are talking about extent of resection, EOR. Now we have to get used to the term EOA, which is extent of ablation. So what size did you actually kill of the tumor? And in this case, he was going back to his cases. He was saying, using the fiber tracks, how many times did I overlap my ablation into the fiber tracks? And how are these patients doing? And you can see this is the lesion here, for example, in this case, and they were ablating bigger than this lesion, and these patients were not doing well. So he strongly recommended, if you are eloquent, to use fiber tracking and not to ablate above this border, basically. And I think that's very important because they had some complications and they were brave enough to share them with us so that we don't make the same mistake again. So that's a very important paper, and we were happy to use this and didn't have devastating results so far. So we learned from them, and we earned their trust. Now, another paper which is nice, it sounds very good, but it's kind of a self-fulfilling prophecy, because they said if we were able to ablate 98% of this lesion in GBM, then the survival rate was 20.3 months. That sounds great. However, that means the GBMs were less than 2 centimeters. Now, if you take GBM patients with 2 centimeter tumor and you take GBM patients where you have a 6 centimeter tumors, there is a giant, even if you take it completely out, there's a huge difference in overall survival. So there's no surprise in this result. But again, it shows that complete resection or complete ablation of a malignant glioma and is of benefit in general. This number is probably too high, but in general, it is worthwhile. And ablation could be as effective as open surgery, basically. Now, there are other centers that are not talking about neurosurgery, but they are thinking about the blood-brain barrier. So BBB is the blood-brain barrier. And if we can break down this with ablation or, for example, focused ultrasound, then medication can go into the tumor better. So the idea was here to use laser in different patients. And you can see that a couple weeks, it starts very early in the first week, but more up to 6 weeks, they had this rupture of the blood-brain barrier. And this certainly could help. It's just a theory, but it could help for immunotherapy treatment. So if you open the blood-brain barrier and if you give immediately treatment, then those cells should be reached faster and better by the medication when the blood-brain barrier is open. The same theory we have on the focused ultrasound side. It's a very interesting idea, especially that more immunotherapy ideas coming up, and they would certainly profit from this. Now, again, another case. I'm starting to mix a little bit because, again, you have probably not seen many of these cases. Again, you see a post-central lesion. It was a glioblastoma recurrence. Post-central, yellow ones are the sensory fibers, motor tracts. So again, eloquent lesion. He had operation chemotherapy. He was in good shape, so we decided to do a laser therapy for the posterior one. We planned this lesion, we ablated it. You can see this is the catheter. This is a fresh picture from the MRI with the catheter and the ablation. The little black spot that you see here is a little bit of air because we did a biopsy. The company is always not happy if we do that, but we have to do that to tell the patient it's a tumor, etc. And then the risk is that you leave a little bit of air, and that actually disrupts a little bit the computer software because they cannot calculate the heat around this anymore as nicely as before. So then you have to estimate as a surgeon. Now you see this was the planning and this is the ablation. So the extent of ablation was slightly bigger than what we planned for. And again, this patient had a little bit of hemiparesis right after surgery. And we did give some cortisone immediately. He recovered very fast and he could go home. And then with combination of Avastin and laser therapy, you can see 4 months after this, you see the lesion was stable, no contrast, of course, because of the Avastin, but the patient was doing very well. He had no sensory deficits and he could continue working actually. What we experience is that with fixed coils, it's very difficult if we come with the catheters from behind. So we changed to the flexible coil so we can put the patient on the side. We had, I don't know why, but we had a lot of patients where we planned the catheter coming from behind. That's not all of them, but that helps a lot. So this is our new standard and the images are the same. So this is how we do it now in St. Gallen. It's basically the same thing as you saw before. So it's a good repetition. So we put in the frame, we place it on the patient. This patient was 82 years old. She had actually an intraventricular meningioma that was growing within 2 years, double size, but she was doing perfectly. But open surgery on an 82-year-old to get out basically, how to say, asymptomatic but big meningioma was not good. So we told her we can just denaturate this tumor. So you can see again, you go to the CT, you make the planning CT scan, then the CT scan is again fused to the navigation system, to the MRI where you replant the tumor. You can see this here. This is the intraventricular meningioma, which again grew very fast in 2 years. So we do this planning. And then I will skip a little bit. This is the planned trajectory of our catheter going into the lesion and trying to be in the center of it. And then in the operating room, again, it's mini incision, a mini burr hole, that's it. So basically you just need one stitch at the end. You know, the burr will stop exactly once the bone is through and through the meningia. We do a biopsy. Just quick, again, in the meningioma, in the tip of the, in the center point. And then we include the catheter surgery placement, the laser placement. There's a bolt you put in first. This gives you the direction again. And then through that bolt, the catheter is placed. And of course, the fiber with the laser light at the end. And then the patient is brought to the MRI again. And in the MRI, we do first some scans if everything is okay. And you can see here we're heating now. You can see the heat is growing. And there you can already see after first ablation, we pulled back the catheter again. And you can see we're heating. In the center, we have already 50 degrees. In the middle, outside, we have only 40 degrees. So we're constantly mapping every couple seconds how the heat is doing. And at the end of the MRI, we see a lot of the tissue is dead. And basically in the MRI later on, we could see it's 50% of the tumor was dead and the patient didn't notice anything. And now look at the patient. It's 7 days after surgery, but it was the same a day after surgery. She didn't feel a thing. She couldn't even remember. She said, did you really do something? And we said, yes, we came from behind, etc. And she didn't feel it. She was very, very happy. And this, honestly, you can get only with laser therapy or radiosurgery. You don't get this with open surgery. So we have time now for this patient. She's 82. We can look for the benign meningioma for a couple while now. This is a very interesting case. So this is a 57-year-old female. You see a deep-seated, most likely malignant glioma, had some hemiparesis. We knew we could only biopsy it or laser it, but we could not do open surgery. Nobody wanted to do it because we thought she already has hemiparesis. We'll make her hemiplegic. So we offered laser therapy. She said yes. We needed 10 days to organize everything, to get everything done. And look at this image. 10 days later, this lesion has grown 6 times bigger. And we actually wanted to abandon everything and say, that's it, we just make a biopsy. But the patient also asked us to continue. We said we can't ablate everything, but we can ablate a lot of it, maybe open blood-brain barrier, as we thought. So we did a laser therapy, you can see, and we did a pretty large ablation. Not everything you see on the lower part here, you see a little bit left, but we did a big ablation. Again, the black holes, those are the air that came inside. Again, not super duper good, but again, that's what happens if you do a biopsy. And then you cannot trust basically the calculations anymore. But we estimated that around the catheter, 1.5 centimeter, we would have a good ablation. You can see this here. Also in small video again, you see the yellow dots means that it's already dead tissue. And if you go back, if you slide back, you can see the temperatures around it, very hot in the middle. Tissue dies quick, or you have normal heat on the outside, and then it takes longer. So in the upper part, not so much tissue is dead than in the actual trajectory. So interestingly, this lesion, just 3 days after surgery, because it was so big, people started again with lomustine and temozolomide. She had radiotherapy, and then 3 months after all this procedure, the lesion basically collapsed again, and the patient was actually back to work and had a really we didn't believe this kind of recovery of this patient. We thought she's lost, just do biopsy and that's it. But she came back very good, even clinically, and was back to work. So again, this was the lesion just 10 days after the first lesion. This was the planning and the laser therapy. And then 3 months later, the whole lesion collapsed back to where from the initial image, basically. This we've seen. Another patient with a glioma and a radionecrosis, again, mini incision from the back, ablating this lesion, taking care of the temperature here. This time we came from the back because we couldn't come from the craniotomy side. The craniotomy was actually disturbing our bolt to put the catheter in. So we came from the back to have also a better trajectory. And we thought it's a radionecrosis, so we didn't ablate all of it. And this is what we learned from the paper from Chang. You don't have to ablate the whole lesion. If you ablate more than 50%, you just change the cycle, and then basically the radionecrosis collapses. And this is also what happened here. See, we couldn't come through the craniotomy, so we came from the back. We used this line instead of the short blue direction. And you can see the day pre-surgery, you see the edema in the T2, and then right 4 weeks after the laser therapy, the edema is almost gone. And then 3 months after laser therapy, the edema is really almost gone. So this helped a lot. So it was clearly also helping for radionecrosis. Now I'm coming a little bit to the end. And there is a funny idea, because when I grew up, I knew that butterfly glioblastomas, just biopsy them, right? So you biopsy them and you send them for radiosurgery, for radiation, or maybe chemotherapy nowadays. But butterfly glioblastoma, that's the worst thing. However, the group from San Francisco, they did a lot of resections on these patients, and they said if the Karnofsky scale is not so bad, then patients actually profit from a complete resection, so from a more extensive treatment and not just biopsy. And so basically using laser therapy, you could combine this, because butterfly gliomas always, are more like two sausages growing up. And one idea could be, in a study that we are thinking in Europe, is to combine it, come from both sides, biopsy these butterfly gliomas, and then basically laser them from both sides to take care of the lesion. Now, laser therapy is currently used as a treatment for some focal recurrent gliomas on a personalized basis, so we don't have real randomized controlled trials or huge evidence. We have to be very clear here. We can't say that this is the golden standard now or something. Only well-designed trials will prove that better, and we are working on some ideas here in Europe, and I know that in America a couple trials are already running with some special immunotherapy treatments. But however, there's very, very good evidence for radionecrosis and also for epilepsy. And the concept of superior efficacy of immunotherapy because of blood-brain barrier disruption through laser, yeah, that still has to be proven. So it's a good idea. It's a great idea to think about, but it's just an idea for now, and I think we should not sell it too much. So in Europe, we are thinking about a register, so combining all centers that do tumors, that do gliomas, and combine our knowledge. And actually to keep up with the Americans, because they have like a 9-year head start of us. And unfortunately in Asia, I asked the company how are the plans right now, but they couldn't tell me anything official. So in Asia, you would have to wait. There are some Arabic countries or cities that might start it soon. Yeah, we'll see what the future brings in this part. I can also say there are two companies who do the same procedure, but for now in Europe, we have only one company with a FDA approval or European FDA approval. So there's basically a monopoly right now, and we are dependent on it. So it will not revolutionize neurosurgery. It will not take away microsurgery, but we believe that for some cases, tumor cases, this can be beneficial, especially if they are in their later days of a treatment and they want some treatment, because those patients can go home next day and don't feel a thing, and you're not taking away 1 or 2 weeks of hospital, although they only have 2 or 3 months to live. So that's a very important thing, and the smile of these patients after this procedure motivates me at least to do this, to continue this procedure and dig deeper into all these ideas and concepts. So thank you very much for listening to me, and I'm looking forward to your questions.
Thank you very much, Professor Bozanov. That was an outstanding tour de force of your outstanding experience. Thank you. You brought up a very good point in terms of the artifact, the air artifact created by a biopsy. And that's one of the things we struggle with a lot, because on the one hand, we want to take samples from all 4 quadrants, etc. Do you find that sometimes you may change your normal philosophy, like maybe limit the number of passes that you go in and out in anticipation of lit?
Yes. Well, first off, that's, I mean, I can see you have the same struggles as us, of course. Well, because most of these patients, they are in the board, the oncologist says we need another sample, for example, right? So that's the main indication. And then we say, well, since we have to do a biopsy, we can also, take care of this lesion with laser, which is no problem for radiotherapy, which is no problem for chemotherapy. So we don't make it trouble for anybody, basically. And then, of course, the patient and the oncologist says, yeah, do it, right? Mm-hmm. But the main goal is the biopsy. So we need to have tissue. Yes. I have to say that we tend to do a tissue resection in the middle of the lesion to have, of course, a biopsy, but also if there's air, then we can ablate more than the air. You know what I mean? Like we can be more aggressive in the middle of the lesion, whereas on the tip of the lesion or in the lower back, you have to be more careful not to ablate direction of eloquent tissue. So that is the only rule so far that we have regarding this.
Yeah, that's a great tip. Regarding there's this notion that, as you mentioned, with the GBM and drug therapy, immunotherapy, that lit disrupts the blood-brain barrier. How do you think that works with radiation necrosis? Because the theory there is you have these leaky blood vessels. So, I'm just curious, what do you think the mechanism?
That's a good question. It's the biggest problem is we don't even know why there is radionecrosis. So how that happens. I think I'm really not that big of a scientist in this area to make a very good answer to this. But I think what you do, you help the body basically to overcome. It's like a chronic subdural hematoma. Why is it helping that you just make a small hole and put some water in it? I mean, it's a giant lesion. It's a chronic subdural hematoma is a giant disease, and you just put some water in it and then it dissolves, right? Yep. It's kind of the same thing. You do something. You open the door, and finally things can go in. And I think that's kind of the same, like an abscess or a subdural hematoma. You make a hole, and the rest the body takes care of it. That's my explanation of it. Sorry, not very.
No, I think that's a great point. And I wanted to make just, I guess, a couple of comments in terms of MTS, mesotemporal sclerosis. I think right now still there's few centers that are doing lit first then surgery. I think there's still a good number of centers that are going with surgery.
For pediatric?
For adult, I can comment. I don't know about pediatric.
Yes, for adults, but not for peds.
Correct.
Yeah.
Yeah, and then have you considered, I don't know if you guys have the equivalent of an O-arm, intraoperative CT, for the spine cases. I think in terms of workflow,
Yes.
that's what has made our life easier. Do the O-arm spin right there in the OR.
Yes,
Yeah.
would be great. Absolutely. But what I wanted to show is just that right now we are in a different building. So in the next year, we will change to a building where we'll have CT, MRI right next door. So that will help a lot. However, it should not discourage you to use this technique. You know, if you have to go with this patient that just has a catheter in their brain, but with a bolt, you can move the elevator down to the MRI, and then after the MRI, just pull it out. You don't need an MRI, you don't need an OR anymore. The OR doesn't have to wait for you. So, you know, even if you have long distances, you can still do the same procedure. That I'm just saying this because in 2018 or so, when this company approached me, they said, "Oh, you have an intraoperative MRI. That's perfect. You should do this case." And we said, "Okay, we'll try. We'll be the first ones in Europe to do it." But honestly, you don't need to have an intraoperative MRI. You can just put it in and then go to the MRI wherever it is. And just need anesthesia to be good, you know, to come with you because the patient. So that's why I showed it. But of course, if you have everything next to you, then it's very quick procedure. However, what you didn't see or what I didn't mention is that the whole procedure takes 2 to 3 hours. You know, biopsy, go to the MRI, make some scans, do the ablation, which takes 5 minutes, but then another MRI to see if the ablation was good. Then the patient comes out, you pull out the catheter, it takes 3 hours. So it is a time-consuming procedure because there are so many safety issues, so many protocols. It's like flying a plane, you know.
I was just going to say that.
In open surgery, we just, okay, team time out, it's the right patient, left side, yeah, let's go. You know, but in laser therapy, you have a lot of lists, you know, did you do this? Did you do this? Did you do this? It's kind of flying a plane. So it has a lot of safety procedures, but that makes it very safe. I have to say that, you know.
Absolutely. I love it.
I hope you agree.
Yes, absolutely. We have a question from the audience.
Cool.
Dr. Eng, did you want to go ahead? You're on mute right now.
Yes. Hello, I'm Dr. Ben from Hong Kong, and may I congratulate your excellent result for this minimally invasive technique for the laser therapy, Professor Oliver. So I have some questions. The first question is about the patient selection. So is there any size limit or any location particular selection for doing the laser therapy and versus the open surgery in your unit? My second question is that there is I can appreciate that from your case series. The mostly you need to upgrade those contrast enhancing area on the MRI. So because like in glioma, sometimes the lesion is not very contrast enhancing, or there is some T2 flare for those with glioma. So how would you plan your area of ablation or on your MRI? Do you include some of the T2 flare signals in the MRI?
Yes. So I will start with the second question. It is absolutely your choice which MRI you use. You can completely plan your procedure with T2 or T1 with contrast. That's your decision. You just paint it in whatever you want to ablate, and the computer can take this up. So it's morphing the one range image to the I forgot the name, but to the temperature basically image, and it's overloads or overlaps them basically. So that you're free of whatever you want to do. Now, low-grade gliomas that don't take contrast enhancement mostly are bigger than just 2 centimeters. I'm just saying this. If they are just 2 centimeters, then yes, you could ablate them too. But maybe you should consider also taking them out, because there's very good evidence if you take them out. And since you have good evidence, yeah, and those are superficial, which brings me to my first question. What are the best lesions? So we do not like to do laser therapy on very superficial lesions because it's easy to get on them. Open surgery, small craniotomy or something. It's not, you know, they're not dangerous, quick surgery. So we do but if it's a deep-seated lesion, you have to go through 3, 4, 5 centimeters of tissue before you come to the tumor. I think those qualify very good for laser therapy. So my hobby is brainstem surgery. Okay, so that's my happy thing, and I'm kind of fighting against me, because I always said maybe someday I can use the laser in the brainstem instead of doing dangerous open surgery. But for now, I think we have stopped at the peduncle. So we go cerebellum, peduncle, yes, but we haven't gone into the brainstem yet. I know some colleagues in the US, they have some cases with brainstem laser ablation. Case reports, I would say, some good, some not so good. So for me, I stop at the peduncle, and I would stop also in the basal ganglia if I'm above the brain. But you've seen the thalamic one worked very well with laser therapy.
Yeah. So thank you, Professor. And I also see that during your video, you have different kind of frames that you use. Which one do you prefer?
Yeah,
is there
that has to
any
do
preference?
Because I'm not a stereotactic neurosurgeon. So in Zurich, I work with the stereotactic neurosurgeons. And now I'm here in St. Gallen and I work with it. So they decide what frame they use, basically. And we have the classic Lexel frame now, which I learned now too, because I like laser. So I had to learn it too. And it works for me well. But I have some experience with navigated laser. And I have to say that the tip of the laser is not perfectly there where I want it. So like 2 millimeters apart. And that actually plays a big role, because if you have a circle and it's not in the center, it's a little bit more left. If you ablate, you will ablate the smaller part nicely, but you don't get to the border of the bigger part. So I can recommend only to use stereotactic insertion, or maybe super duper robotic insertion, just to be perfect. Otherwise, you will have an uneven ablation of the lesion.
Yes.
I mean, Dr. Mansour, I don't know, would you comment on that too somehow?
Yeah, I think locations, we try to look at the sensitive structures around it, like brainstem, and we do try to incorporate fiber tracks. We don't want to disrupt those important fiber tracks, because at the end of the day, it is ablating, it is destroying. Otherwise we do consider it an ideal one for deep-seated lesions, right? So
thank you, Professor, and congratulations on your result.
Thank you for the invitation. It was a real pleasure.
May I ask some question, Professor? Thank you for very nice presentation, Professor. I wanted to find out regarding brain metastasis. In your experience, how many lesions at one time can be treated? I mean, how many burr hole can be done in those cases? My second question, Professor, what are the youngest age of patients have been treated with this? Because with radiosurgery, we have limited to age not below 4 or 5 years old. So in your case series, what the youngest age can be treated with this modality? My last question, Professor, do you have any troubleshooting procedure? For example, like heat building up too fast or bleeding after biopsy? Is there any troubleshooting procedure for this? Thank you, Professor.
Oh, good. I will start from the end and go backwards, basically, with the question. So, of course, we have one case where we had a small bleeding, but you just do a biopsy. So rarely you have a big, a big vessel that you biopsy. That's rare if you're deep in the brain, right? On the small bleedings can happen. That's it. That's like in every biopsy, it's 1%. And then maybe you cannot do the laser therapy, to be honest. That could happen. Yes, we didn't have that yet, but that could happen. Other than that, you have to be careful. If there is a vessel near to your lesion, it actually cools your lesion. So you have to burn harder to get, you have to calculate things like ventricles or vessels, because they actually cool your tissue very fast again. So in that area, you cannot ablate. Now, the second question was with the age of the child. My youngest was 6 years. I don't think there is a big problem doing it on 4 years or 3-year-old children. But again, these children have a disease that you should consider standard therapy first. I'm just saying this before you do something like laser. But I would not be surprised that in some cases this could play a role. We have some kits actually for recurrent tumors we really like to use laser therapy, but they're older so far. And the first question is, and I have to admit this, I had a talk about this at the JNS, the Japanese Neurosurgical Society, in front of a lot of people. And the chairman asked me, why do you do laser? Why don't you use radiosurgery? You know, and he's right. There is no. I mean, of course, radiosurgery is your number one. That's not the question, right? The question is, does it make sense to add something, to add surgery, to add ablation to radiation, or after second radiosurgery, the lesion is still making trouble, then you can use laser. So laser is not here to replace radiosurgery, no, not at all, but to be a second choice. I mean, a surplus on it, an amendment, or what you say, you know, to use it. So that's it. So I would never use laser on 5 different lesions and ablate them all. That's stupid. Take radiosurgery for all of these things. But maybe one of these 5 is making trouble, is not dying. Then you can kill it on top with laser, for example. So that is the idea. But it is not, it is complement. It is not replacing radiosurgery. Okay, please don't go out and say, Dr. Bozanov says radiosurgery is stupid, we should do only laser. That's not my message.
Thank you very much, Professor.
You're welcome.
If there's no further question,
we have a question from Dr. Parekh.
Thank you very much, Professor. Excellent talk and very, very innovative techniques. You brought it to our notice and make us enlightened. Wonderful. My first question is, how expensive is this machine which you are using? Second, how often, means how many times you can use this probe again and again? And third, I want to know, if the lesion recurs, then can you use it again? Thank you.
Yeah, that's a very good question. I'm very happy that this time I'm invited alone and not by the company, so I can give you my my real answer to this. And I will start at the end again. So the good thing about ablation is you can do it every day. You can ablate more tomorrow, Friday, again and again. It doesn't matter, right? So it's not like radiation. There's no limit of it. It might not make sense anymore at some point, but you can do warming as much as you want. However, so this is the problem. It's not just the catheter. You need the computer to control the MRI, right? And the computer, you have to either lease or you buy it. We have bought it, so it's ours. However, again, we are in a country where they sell us the catheter as a single use. We cannot use it again. It has been in the brain of another patient, so we cannot use it again. You cannot sterilize it or something, right? So that makes it basically impossible for us to reuse this catheter. There's no doubt that you could use it 100 times. It's not, if you don't break it, it's functioning. But we must not use it on a patient again. And then comes the first question. So how much is one catheter? And that's a big problem. That is a problem because it's a monopoly of this company. And right now we do pay $10,000 for one catheter for the whole procedure. That's what we pay. Wow. That's our price. So they come, they help us. We have the procedure. We take the catheter. So the whole procedure costs $10,000. And that means also that we in Switzerland, and we are a rich country, right? We do lose money on normal patients, normal insured patients. But if the patient has a private insurance, we make more money with the same procedure. And so combining these two, we are okay. We're even. We get our money back. So we have to have these private patients. We have a lot of them in Switzerland, so no problem. But to pay for the not private patients, to have this whole procedure basically for us making not losing money. But if we do it only on private patients, for example, to make money, then we don't have the experience, right? So yes, so this is the calculation right now. How much is it in America? Could you comment on this?
Yeah, I was going to say the catheter is around 4,000 or 5,000.
Yeah. But you have 2 companies in America.
Exactly. I was going to say that there's no monopoly here.
Yeah.
Wow. That's huge.
Yeah.
And there's also the cost of the personnel that needs to anesthesia and the people down in the MRI.
Right. It's only the catheter, yes. Yeah.
Wow.
Thank you very much, Dr. Oliver, and for very nice presentation. And where we may hear the concluding remark from Professor Ali Reza. Professor?
I wanted to echo your sentiment, Professor Bozanov. That was fantastic. I think we got a good tour of all the possible indications, and I really think with technological innovations, we're going to go more and more minimally invasive, like even just a biopsy, right, with a 2-3 millimeter drill bit. That's just amazing. So thank you very much for showing us all that data. Your first slide was excellent. Without data, you're just another person with an opinion. So this is great. Thank you.
Thank you. We will proceed with the second webinar. I will call upon Professor Ashikumar to call upon our second speaker. Our second speaker is here, Professor He Chuan. Professor He, are you here, Professor? Can you on your camera?
Yes.
Okay, I'm here.
Okay.
Morning, everyone.
Yeah.
Hello. Good morning,
Hello.
everyone. I'm actually in between a surgery just finished, so I apologize by joining from my mobile. But we're happy to be here.
Professor He Chuan, you may share your slide, Professor.
Yes, okay, thank you. Introduction. Okay, my lecture should be on the cranial cervical junction dural artery venous fistula. And I come from the Shanwu Hospital. Our hospital is one of the biggest neurovascular treatment center in China. We have about 10,000 surgery treatment in 1 year and about 4,000 neurovascular disease in 1 year. So my topic is the CCJ DVF. My definition of the CCJ DVF is the cranial cervical junction located and artery venous fistula, and not included the lower cervical spinal artery, spinal cord, or the hypoglossal canal. In the last 3 years, we have 65 cases, and the patients, some presented with the SAH, some is the spinal dysfunction. And the angiography of in the 65 cases is the fistula located and the nerve root as the foramen magnum is the 55, and at the C2 level is 10. Fini artery coming from the external radicular artery is 56, and the intradural spinal artery is the 9. And the draining vein is the descending to the spinal venous system is 45, and go upward to the intracranial venous system is 20. The treatment of the 65 cases is the draining vein disconnection was performed with open surgery, all of them, and 12 cases with the venous varix bleeding vein coagulated were performed during the open surgery. In 9 cases with a spinal aneurysm, and the 5 aneurysm was embolization. 4 aneurysm was dissection with open surgery, and 3 post-operative complication was observed. 2 underwent the ASA aneurysm embolization. 1 underwent the ASA aneurysm dissection. The Fini artery is coming from the 3 kind of vessels, and from the ASA is the anterior spinal artery aneurysm, and the LSA, lateral spinal artery aneurysm. Some is from the radicular artery, is the extradural vertebral artery. So this is the one of the cases is the anterior spinal artery aneurysm. Patient is suffered from the SAH. The CCJ DVF feeding artery with the ASA and the C2 radicular artery. And we can confirm that with the angiography and the open surgery. In the lateral spinal artery aneurysm observed, CCJ DVF feeding artery with the LSA and the C1 radicular artery. From the microcatheter angiography, we can confirm the aneurysm structure on the PICA. And that is the PICA raising to the lateral spinal artery. This is the bleeding point. And we perform the embolization of the aneurysm structure and perform the open surgery with the genuine dissection. This is the vena vertebral artery, external radicular feeding artery, and we can confirm the genuine interdural and go upward to the brain. So the relationship between the genuine and the symptom is very interesting. Intracranial genuine causes the venous varix and aneurysm, which result in the SAH. And if the genuine go downward into the spinal venous system, will lead to the spinal dysfunction, just like the SDAVF. So first of all, we perform the descending venous genuine caused the spinal dysfunction. This is the case. 35 years old male, and he suffered from left extremity weakness and numbness for 3 months. And the fistula located at the CCG, and the genuine go downward to the spinal cord. Is another case with the genuine ascending to the venous to the brain, and we can see the aneurysm structure on the genuine with the bleeding point, and we can perform the open surgery and confirm the structure. So this is the ascending venous genuine into the intracranial sinus. Is the bleeding point of the SAH. So for the CCG-DVF treatment, we can perform the endovascular and treatment and open surgery treatment. Which is better is the big problem. First of all, the feeding artery approach fistula embolization is very dangerous because there are too much anastomosis between the fistula feeding artery and the spinal artery, including the LSA and the PSA. And the LSA and the PSA is not shown in the angiography. We cannot know the groove into the feeding artery or the normal spinal cord artery. So if you perform the embolization, onyx is more dangerous because it will cause the occlusion of the spinal artery. Ischemia of the spinal cord will be happening. So, but if the spinal aneurysm was observed in the SAH case, the embolization is selective. But in the embolization, the NBCA should be better. It's global, and onyx will be limited. And on the other side, open surgery should be born reasonable. This is the resection of the ASA aneurysm structure with open surgery, but it's a challenge because the aneurysm located at the ventral side of the spinal cord. We have to retract the spinal cord and explore the ASA aneurysm structure like this. And the fistula genuine dissection during the open surgery is more safety because the genuine always come from the ventral side of the vertebral artery. Sometimes it's coming from the C2 level, the ventral side of the nerve root, and it's very easy to explore. And we can dissection the structure and treat the fistula. This is one of the patients we can see is suffered from the sudden optical cervical pain and with the vomiting and nausea. This is the angiography before the operation, and during the operation we performed operation in the hybrid operation room. So we dissected we explored the aneurysm structure and the genuine origination of the genuine is but during the operation we found that as the big structure, aneurysm structure cannot shown. So we performed operation angiography. You can see it's almost very closed. And we dissect the structure. And during operation, angiography showed that the aneurysm structure is thrombosis, cannot be shown again. And after that, we confirmed the origination of the genuine. And at last, we can calculate the feeding, the genuine next, very close to the dural. So another case, this is another case of the CCJ-DVF, is the 52 years old female. And 2 weeks ago, he sudden onset the neck pain and nausea. We have showed the angiography before that. So we can confirm the aneurysm structure with the microcastle angiography. It's the believing point. And first of all, we analyze the aneurysm structure with the groove. And after that, we trace the genuine with the open surgery. And we can see first I clip the genuine, and during the angiography open it, and the venous system can be shown very clearly. So I calculate the origination of the genuine next to the dural. In this operation, the aneurysm structure treatment is very difficult and maybe challenge, but we perform this with the endovascular. So it's more, sometimes it's the safety. So this is our experience of the CCJ-DVF, and the CCJ-DVF angio structure, angio architecture must be considered carefully, which is distinguished with the CCJ perimedullary AVF. And the CCJ-DVF caused not only the spinal dysfunction, but also the subarachnoid hemorrhage. The system is related with the genuine direction. Go upward, it causes the bleeding. Go downward, it causes the spinal dysfunction. And the CCJ-DVF treatment should be focused on the genuine and the venous varix and the spinal aneurysm. The open surgery may be the first consideration for the genuine disconnection. And the fistula endovascular is very dangerous because the spinal ischemia should be happen. Thank you.
Thank you, Professor Pichuan. It was an interesting talk. I just wanted to ask about one thing. Was there any particular incident you remember when you had to use a combination of endovascular and open surgical approach for these?
You mean the
I saw like in cases of aneurysms, probably you will still try to embolize it, followed by disconnection of the vein. But was it any case where you have to approach it in a hybrid way during the same anesthesia?
I'm sorry, you mean you just perform the open surgery, not the embolization treatment?
Yes. So what I was asking is, like, sometimes you'll have to do both the procedures in the same session, that you can take care of the aneurysm endovascularly, followed by disconnection of the vein by open surgical approach. Have you faced certain situation like this before? or you always stage it, like you take care of the aneurysm by endovascular means or directly surgery, and then in the separate session you come back and disconnect the vein?
Yes, first I will consider whether or not the aneurysm structure is open surgery is possible. If not possible, because I will perform the endovascular treatment, because sometimes the aneurysm structure is just located at the ventral side of the spinal cord. It's very difficult to explore that, and coagulating and the dissection is not impossible. It's impossible. So I have to perform the endovascular. If possible, I favor is the open surgery, treats the aneurysm structure and the genuine together one time.
Yes, thank you. No, because it's very important message which you conveyed that for dural limb fistulas, number one, especially for spinal dural limb fistulas, open surgery is the treatment of choice, because to gain that access into the vein by endovascular route becomes difficult, and the risk of complications are high. So that's very well said. The target is always the vein. I just wanted to know, in long-term follow-up of your cases, these patients many times present with, long threat signs, brainstem dysfunction, cervical myelopathy. What's been the outcome, like the long-term outcome in your case series?
The long-term, the result about the spinal dysfunction is that like the SDOF as spinal dural artery venous fistula is very is almost the same. And because we have about 500 patients about the spinal artery venous malformation, so I can confirm that. I can be sure of that. And about the SH, everything is okay, because we treat the genuine, treat the aneurysm structure. Everyone is no long-term complication, and the good result. Okay.
Because in my experience, we have a few patients where we have to do a tracheostomy just because of significant brainstem edema, especially at the cranio-cervical junction. I'm not sure, whether you required any tracheostomy or any ventilator support for these patients in the short run, just to tide over that medullary edema.
Yes, if the embolization of the feeding artery is very dangerous, if you during the embolization, the spinal ischemia happen, the result is not good, and the patient cannot recover. But so I favor is the open surgery, not the endovascular.
Yes, endovascular treatment in these cases are always, should not be done, and maybe I'll say the second most common, procedure after the surgery. But when you see the angiograms, and especially for the young neurosurgeons, when you see the angiograms for these fistulas, sometimes you feel it's very daunting. There are a lot of vessels going in the brain and coming in the spine. But the good thing which you need to do is to see it frame by frame. And if you identify the site of the vein, that's where the surgical access should be directed towards to. So thank you so much for your talk. I think these are one very rare kind of vascular malformations of spine, where you will have to plan it before. You cannot, it's a touch bit higher because of the surgical access and the difficulty to reach in front of the medulla or in front of the brainstem sometimes. So congratulations. I think that was an excellent case series which you showed. Thank you so much. Professor Liu, if anyone has a question.
Yeah, I have two questions for you, Professor. Probably after that will be Professor Haschat. I wanted to ask whether in the CV junction, do you do laminotomy with laminoplasty or laminectomy? Meaning, do you put back the cervical bone? My second question, Professor, I believe when you talk about aneurysm, you're talking about arterial aneurysm. And do you need actually to treat if there is a venous aneurysm, or is just by disconnecting the fistula we do without treatment of the venous aneurysm, Professor? Thank you.
Thank you. So for the fistula, I just treat the genuine, and if no the bleeding point, we do not treat the aneurysm structure and the genuine. our feeding artery. Yes.
Dr. Harshad, you may ask question.
Hello, Professor. Very, very nice cases you have shown and wonderful. Difficult, challenging problem. I just want to know if the patient is presented with some kind of a neurological deficit with some because of hematoma or a lower cranial nerve palsy, and after either surgical intervention, you occluded the vessel. What is the outcome of this cranial nerve? Suppose they are involved, or if there is a paralysis which is there, what is an outcome you see in your cases, your large number of series?
Yeah, thank you. It's a good question. And during my treatment, if the patient do not perform do not treat the fistula, he will be the system will be very serious in 5 years. And after this open surgery, the symptom will be stable. Maybe cannot walk very well, but he can walk by some support. So the treatment can keep the patient's spinal function stable and then can keep him not to be more serious. Is our outcome. In fact, because spinal cord is very is difficult to treat, so the improvement is not very satisfying, but we can keep it stable.
Even our experience is the same. The recovery is never 100%. Most of the time, we stabilize the disease, and patient still remains handicapped in the various ways in this kind of cases. Especially if you have done an MRI which shows an hyperintense signal in the cord or in the medulla, then the reversal of the symptoms is less likely.
I think this was the point which I was trying to make even before. Like many patients are present with brainstem edema and they undergo tracheostomy. Sometimes they undergo PEG, like gastrostomy. And in one situation, I remember like there was a patient where he had a cardiac arrest just prior to the surgery, and because of the significant brainstem medullary edema. So if another point to note is like if the patients present with significant brainstem medullary edema, it's better to intubate them prior rather than, because they will compensate till a certain point of time and then they will decompensate. Overall outcome, as Dr. Parekh, you said, like it's not satisfactory. They will be on a long-term ventilation. They will have associated pneumonia. They'll have certain infections, and the recovery will be very slow. Even if you have treated the fistula very well and the vein is disconnected, still the outcome for them to achieve like a great recovery is pretty bleak. So it's a bad disease. I mean, the only thing which you can do is hopefully catch it early before signs of cervical myelopathy or brainstem dysfunction.
Yes. So for the spinal cord AVF, we have to treat it earlier and diagnosis earlier.
If anyone has questions,
you have any question?
Yes. So thank you, Professor Hall, for your great lectures, and I can see that you have a great number of cases, and I can appreciate that you prefer open surgery for craniocervical junction and upper cervical spine dual AVF, and I think the same is for me as well. So because as mentioned by Professor Kumar, so sometimes especially after the embolization, that if the feeding arteries get jeopardized or the draining ring get composed afterward, there will be some spinal cord symptoms, and that could be quite dramatic to the patients. So my question is about although it's not mentioned in our in your lectures, but I would like to know, because of the large case number in your center, how about those patients under having cervical AVM? For the patient with AVM, so how would you treat these patients in your centers?
Yes, for the spinal area, and in our center, about 60% was performed with the endovascular treatment, and 60% was the open surgery. Because the open surgery can resect the vein resected malformation completely, but the embolization just keep the symptoms stable and keep the patients not become more serious. And this is one. But in the AV spinal artery malformation is very complicated. Sometimes we have to just keep control the symptoms, but not treat it completely.
Yes, because I think it's quite variable if for the aim of the surgery, if it's come to the AVM, and also the technique you use. Do you, like, for example, do you just disconnect try to disconnect the feeding arteries, or if you try to excise the nidus as a whole? I think is the debate of it. And also, how about the radial surgery? Do you have any experience in your centers that you prefer radial surgery rather than the other two options?
No, the radial surgery just focused on the brain malformation, arteriovenous malformation, AVM, not for the spinal AVM. So the treatment for the spinal AVM is the open surgery and the vascular, both of them.
So, Dr. Ben, I think you're discussing about the AVM or the AV fistula, because
AVM, because I'm
AVM. AVM, not the for the fistula. Jejunum means focus on the jejunum, but the AVM we focus on the nidus.
Yes, because I can see there are many case numbers from Dr. Ho's institute. I would like to ask his opinion on this.
Yeah, I know. I mean, the AVMs and the fistulas, that's the key difference. In the AVMs, you are targeting the arteries and the nidus. And for for dural AV fistula, you always are targeting the veins. You don't look at the arteries at all. Like, you have to just go to the vein and just make sure that the area from where the vein is arising from, and usually it's from the dura most of the times, and you have to just coagulate, put a clip on it or disconnect it. So that's
usually by disconnection is okay for the
Okay, thank you.
Thank you so much.
Someone has a question. Otherwise, I think we have to wrap up.
We can hear your concluding remark, Professor Kumar.
Oh, and thank you so much for this very, very difficult anatomical surgical masterclass, Professor, and your case series is these are very rare cases. So having over 60 cases, it's a pretty good number. So I think we were very enlightened to hear your views on that, and I especially like the last summary slide where you clearly say that surgical obliteration is the treatment of choice for them, and I just wanted to make sure that that message goes across, that endovascular treatment is not the treatment of choice, although it can be done. So thank you so much. It was a pleasure hosting you today at the ACNS webinar.
Thank you, Professor Kumar and Professor Hee Chuan, for very nice presentation and cases that's shown to us as amazing work. And so we wrap up for today's session. On behalf of the Education Committee of the ACNS and President Professor Yukato, I would like to thank both speakers today, Professor Oliver Bozino and Professor Hee Chuan, as well as our chair, Professor Ali Reza Mansouri, and also Professor Ashik Kumar, for the time and support for the ACNS webinar. I also would like to express my sincere gratitude to Professor Zubin for broadcasting this webinar on the WeChat channel. And also special thanks to my co-host, Dr. Ben, for joining us today. And until we meet again on 2nd November, it is bye-bye for all of us. And thank you very much for joining.